So, hello everyone. My name is Nadia Rubaiat, and thank you for joining to me. Today, I will be presenting on the topic of HIV/AIDS in Bangladesh. We will explore the current epidemiological trends, key populations at risk, and the challenges Bangladesh faces, and what strategies are in place or still needed to control the spread of HIV. The first HIV case in Bangladesh was reported in 1989. While the national prevalence remains low, that's only part of the picture. There's growing concern about underreporting, especially in rural areas, and an increasing number of cases among high risk groups like people who inject drugs or PWID and men who have sex with men, known as MSM. Bangladesh is a lower middle income country in South Asia with a population of approximately 170 million. The country faces unique challenges such as high labor migration and extreme population density. Neighboring countries like India and Myanmar have higher HIV prevalence rates, which raises cross border transmission risk and necessitates robust national response systems. Surveillance methods in Bangladesh primarily include integrated biological and behavioral surveillance, or we can say IBBS, which focuses on key populations in urban areas. Routine data collection also occurs in healthcare facilities through voluntary counseling and testing services. However, the urban center nature of these programs means rural HIV cases might be underreported, skewing the national pictures. In 2023, it was estimated that around 14,000 people in Bangladesh were living with HIV, while adult prevalence is officially below 0.1%. Significantly higher rates are observed in key populations. The majority of cases are concentrated in cities such as Dhaka, Chattogram, and areas close to international borders, indicating regional clusters of the epidemic. So, high risk groups in Bangladesh include people who inject drugs, with around 5% prevalence in Dhaka alone. Female sex workers show localized rates of up to 1.6%, while MSN and transgender communities are also vulnerable through underreported. Returning migrants workers are another significant population affected due to higher exposure in destination countries. So, HIV transmission in Bangladesh is mainly through unprotected heterosexual contact. Other important routes include sharing of contaminated needles, unscreened blood transfusions, and vertical transmission from mother to child. Stigma, low condom use, and limited health literacy further exacerbate the spread among vulnerable populations. This figure illustrates the cumulative HIV/AIDS cases in Bangladesh between 1989 to 2022, including those among the Rohingya refugee population. It helps highlight the rising trend in reported cases over time, as well as importance of considering displaced populations in the country's HIV response strategy. The National AIDS or STD program was initiated under the Ministry of Health in 1985. Its primary strategies include surveillance expansion, art program scale up, and stigma reduction campaigns. Several non governmental partners, including BRAC and Save the Children, have been instrumental in implementing outreach and service delivery. Prevention and awareness campaign in Bangladesh have focused on condom distribution, harm reduction for drug users, and awareness sessions on HIV prevention. These campaigns are especially targeted toward high risk groups and rely heavily on both government and NGO collaboration to reach marginalized communities. So despite various efforts, several gaps remain. Art coverage is still under 50%, and most services are located in urban settings, leaving rural populations underserved. Persistent stigma, discrimination, and dependence on donor funding continue to pose major obstacles in the fight against HIV in Bangladesh. This table summarizes the HIV/AIDS situation in Bangladesh, showing prevalence among different key populations. The data underscored the disproportionate impact on sex workers, people with STDs, and other marginalized groups, helping stakeholders prioritize targeted interventions. So our proposed strategy involves a community-based approach. We suggest training rural health workers for decentralized HIV testing and counseling, integrating HIV education into schools and vocational institutions, and engaging community and religious leaders to combat stigma. This grassroots model could be help extend the HIV response to currently underserved areas. In conclusion, we can say although Bangladesh maintains a low national prevalence, key populations continue to face elevated risk. Stigma, service access gaps, and financial constraints are major hurdles. However, with right-based, community-driven interventions, Bangladesh has an opportunity to meet its 2030 UNAIDS goals for epidemic control. So thank you for your listening. The references used in this presentation include data from UNAID, the National AIDS or STD program from Bangladesh, and key peer-reviewed articles such as those by Ajim et al. And Chan and Khan. Please feel free to reach out to me if you have any questions or any comments. Thank you.